So I think there is already a stage set of KEYNOTE-671 study, that is a peri-op setting pembrolizumab, and now we'll be moving to the peri-op neoadjuvant and adjuvant immunotherapy in resectable lung cancer. The most important point here is we are discussing about resectable lung cancer. If a patient is unresectable at the baseline and you are giving chemo-IO as a neoadjuvant treatment, then it is a different. All the trials were for resectable lung cancer. So this should be at the back of mind, that you are not downstaging the disease to make it resectable. This is, all the trials are being done to improve the outcomes in even in resectable settings. So that is one of the most important points which I wanted to highlight. So I will be just highlighting the relevant points related to this KEYNOTE-671 trial. This is what we have seen. This is Pembro plus chemotherapy with Pem or gemcitabine or pemetrexed versus placebo with pemetrexed or gemcitabine along with cisplatin. And the patients you can see were having stage 2, 3A, 3B, as it was being highlighted by Dr. Advait already. Most of the patients were in stage 3. Stage 2, there are a few patients, but they should be resectable. And the surgery was performed within 20 weeks after first neoadjuvant dose. And adjuvant peri-op, this was a peri-op trial, so adjuvant pembro was continued for up to 13 cycles. We had a very good discussion in the previous discussion about 2 years of treatment in metastatic setting. So that's also important. We have a good data set which is available. Extending treatment beyond 2 years is not adding to the survival. So then why to continue treatment? Another point is that here what we are looking at, actually the data is already very strong. You are seeing all the trials were designed for event-free survival. Like in breast cancer we discussed IDFS, invasive disease-free survival. In lung cancer, all the neoadjuvant treatments are designed to check event-free survival benefit. This is the 2-year data set with this peri-op pembro. 2-year outcomes with EFS was 40% versus 62%. So seems to be a quite robust benefit. It is not a very small benefit of 1 month, 2 months, 3 months. It is a robust benefit, and the percentage difference is very significant. And also, what is a major pathological response in lung cancer? Again, I wanted to keep the students busy, so I'm asking this question. What is major pathological response in lung cancer? Anybody? Less than 10. So residual viable tumor less than 10% is called major pathological response. So that's very important to understand. And PATH-CR is, we all know from due to breast, we are so much pro about PATH-CR. So PATH-CR was improved from 4 to 18%. Major pathological response, MPR, was improved from 11 to 30%. So that's quite significant. Now, what happens if patient doesn't have major pathological response? That is what we want to see. So what was done in this analysis, this is RVT, that means residual viable tumor. It was 0 to 5%, 5 to 30%, 30 to 60%, more than 60%. So the data was analyzed according to percentage of residual viable tumor. Can anybody state which cancer you become reminded of by this type of classification? Anybody? Very good, very good. You was grading for osteosarcoma and even for Ewing sarcoma. The percentage residual tumor becomes prognostic. So that is the same analogy which is being implied here. So try to correlate it and try to cross-relate. The same thing which was seen in osteosarcoma and Ewing sarcoma is now being translated into lung cancer also with this analysis. So what we see, if the residual viable tumor is between 0 to 5%, 12% outcomes with placebo, while 31%, this is the data set which is got with pathological evaluable tumors. And if you see, pembro median percentage residual viable tumor was 29.5%, it was double, 52% with placebo. So this is about the downstaging. This plot gives you an idea what was the downsizing of the tumor. And it is, you can compare with the placebo, it is much different. And it was 52% in placebo versus 29.5%. So it's nearly double chances of reduction with you are utilizing peri-op pembro. And if you see again, event-free survival data as per the percentage of residual viable tumor, the same concept I was telling about Ewing's, when the residual viable tumor is 0 to 5%, you are seeing the curve is at the top. That means the best possible outcomes are being achieved. Between 5 to 30, you can see it is slightly below that, but above 30 to 60. And if it is more than 60%, similarly what we see for Ewing's, the curves are much down. So it's clear that the percentage of residual viable tumor is a very good prognostic marker now. You want to achieve path CR, you want to achieve major pathological response, but beyond that also you can look at and have a prognostic idea in your mind. Whether you can do anything to change in the adjuvant setting, that remains uncertain. Even in Ewing sarcoma and osteosarcoma, there is clear data till now that the patient didn't have a very good fibrosis or necrosis post neoadjuvant treatment. Whether do you change the treatment and achieve anything better, this is not established yet. Similar thing will be for lung cancer as well. But I think in lung there is so much explosion of the data, so many targeted treatments. There might be something which will be coming up that you change the treatment in the adjuvant setting as per the responses in the neoadjuvant setting. So that thing is also being planned and under analysis. So this is about the event-free survival outcomes. So to conclude and summarize, the percentage of residual viable tumor is also becoming important when you are using peri-op approach, and your pathologist, again, the importance of these things should be communicated to the pathologist so that they are able to give this data to you when you are utilizing peri-op chemo IO in your patients. So peri-op pembro has already demonstrated a significant OS benefit. So it was also discussed in the previous talk. Till now, this is the only data which has shown peri-op OS benefit because of its longer duration of follow-up. At 3 years, the OS difference is 64% versus 71%. All other trials have follow-up in terms of EFS, but this first time Pembro has a data because it was the first trial, one of the first trials, and it has shown OS benefit. So that's a very important MCQ question. Keep in mind these questions because you will have participate in MCQ on the third day, first session. Thank you for the patient listening.